Hello, Dr. Shrikhande.
Hello, Alex. How are you, Dr. Milspaw? How's it?
Very excited to finally do this Instagram Live with you. We've known each other for so many years now. It's good to connect on social media.
Me too. Me too. I'm excited to share all the amazing things you're doing for PRM and the amazing courses, and it's really great stuff.
Well, you're the leader here. I mean, you have created this amazing organization and really branching out in such an incredible way to really get the word out there, get the information out there, but also really to improve access to patients as well as providers to know all of this. So thank you for paving the way.
No, great. I'm happy to kind of open up with asking you some questions just about all, these amazing courses you're offering.
Well, I'm going to have you start off by talking about the different types of pain, because that really leads into the how and the why I'm doing what I'm doing.
Sounds great. Yeah, I mean, there's really two main types of pain. You have acute pain and chronic pain. And in the acute pain, when there's some sort of trauma to the body, essentially, if addressed within a reasonable time frame and the underlying pain generator is addressed, it will resolve. In chronic pain, the definition of chronic pain is it's something that's lasting greater than 6 months. And with chronic pain, what can happen is there can be real changes in your nervous system. And even when that inciting event, so whether it is inflammation or trauma or some sort of surgery, once that inciting event is removed and the body is technically healed, the pain can persist in chronic pain. And part of the explanation of chronic pain is because of those changes in the nervous system, where there's deeper level changes at the mRNA that kind of make your nervous system go haywire, right? So that is kind of what can happen in the chronic pain situation, and we apply those concepts to treating chronic pelvic pain.
Yes, you absolutely do, and that's what I love about you, and that's what I love about physiatry. I mean, physiatry in general focuses on functionability, and you really look at the whole person and the whole person's life, rather than so many other specialties just zoom in and only look at their organ systems and forget that there's neighbors, let alone a whole body connected to that organ system.
Exactly, completely. That is the key, particularly with the pelvis, right? There's a lot going on, a lot of connections with the entire body.
Yes, exactly. And with pelvic pain and sexual pain, it's in such a core part of the body where there's so many different things going on, and so much of our daily lives revolves around those functions, not only with the bladder and bowel functions, but just the hips and the pelvis and being able to sit, stand, move. I mean, it just incorporates it infiltrates into every aspect of someone's life, which just makes pelvic pain so much more intense, I think, for people to manage, because it's one thing if a hand or wrist or a leg is hurting, they can allow it to rest or they can still function in their lives. But when it's in the pelvis, it really can debilitate people, which adds to the stress response to it. Just because it just gets in the way of life, gets in the way of them having fun. And it's harder to ignore when it's in such a private part of the body.
100%. You really, you hit the nail on the head. It's hard to do pelvic rest, right? I mean, the pelvis is just involved in so much. Any movement, any casual walking to running, sitting, as well as even, of course, bowel, bladder, and intercourse function. So pelvic rest is a challenging thing to do. So I do think that is why when you have issues down there, it really is important to address them early and often to get your quality of life back.
Yes, and to address them early and often, we need a foundation really and socioculturally to be able to talk about these issues and to be able to ask these questions, let alone to be able to talk about them in a way that's not shaming, that's not judging, that's not embarrassing. And too many times I've talked to clients that they've been through not only multiple physicians just to be able to get an accurate diagnosis, but multiple physicians until they've even talked about it. And same with therapists, right? So it's in all areas of where people go to seek help, and they're not getting the training in schools or residencies. And so, again, I think what's huge about what pelvic rehabilitation medicine is doing is it's helping create the curriculum. It's helping create training modules for both physicians as well as PTs and therapists, now that we're all working together and with physiatry and behavioral health and nutrition. It's just really, we're paving the way, and it's so important with pelvic health, because as what you've added to, there's both acute and chronic pain is involved with chronic pelvic pain, because there's not only the central sensitization, which makes all of the nerves and all of the muscles more sensitive and more quickly agitated, but you have the chronic aspect of it where the nerves are firing even if they're not stimulated. But then you add to that the acute pain of those muscle spasms happening, of the organs cramping, so there's both always happening. Mm-hmm. And so many times when people say, well, you're going to go to behavioral health, they're saying, okay, are you saying that it's all in my mind? And we're saying, no, absolutely not. And I think PRM makes that very clear, where it's happening in both places at the same time. And if we only are treating the local aspects of the muscles, the nerves, and trying to heal the organ systems, we're not actually helping address the programming that happens in the spinal cord and the brain. And so I talk to people a lot about that, the brain-gut connection in and of itself, right? Where if there's inflammation in the gut and inflammation in the pelvis, that also leads to inflammation in the brain. And so some of the emotional and mental health symptoms we see aren't only because it's completely intervening with someone's normal daily functioning, but there's a real inflammatory process happening in the brain, which is the perfect setup for things like anxiety, depression, and mood disorders. And then at that point, you have a really vicious cycle going on between the pelvis and the brain.
100%. As I feel like at pelvic rehabilitation medicine, we focus on the pelvis, but it really is that treating that underlying neuroinflammatory process, right? That happens from the central nervous system, the brain, the spinal cord, all the way down to the peripheral nerves, and conceptually working with experts like yourself to kind of treat it all at once, right?
Yes.
Not piecemeal, but all at once is really that secret sauce to our patients better.
Absolutely. And that simultaneous aspect is a question that I get asked a lot, in terms of, well, should I do physical therapy first and then the injections and then the retrain your pelvic pain course, or should we do the course first and then this? And saying, no, if you can, which is why we try to make it as affordable as possible to try to do everything at once. Because so often patients go through maybe a whole year of PT and maybe either, several injections, and they're questioning why they're not better yet. And they haven't been able to really understand the pain education aspect of it. And so they're not able to plan for, what does healing look like? What does functioning look like? How am I healing my brain so my brain's able to click save on some of these new physical postures, new ways of moving, new ways of functioning. And so they're not, and they haven't had the ability to tune into their bodies to notice some of the improvements that have happened, because pain and fear just hijack the brain, and then that's all the brain sees. And so it's hard. I know some physicians have sat down with patients and saying, well, let's look at your functioning when you first came in, and then let's look at your functioning now. And there is always improvement. But again, the brain just really slides back into those old patterns of pain and fear because of the brain hardware changes that happen. And so really trying to highlight the necessity of having all of that at once, so that way when they're getting the pain education and the exercises, to be able to help their brains and their nervous systems really absorb the huge benefits that the PT and the injections can offer them. So everything's healing at the same time. Then they're not, one's not fighting the other. I mean, one's really laying the foundation for all of them to really work. So I really want to get that point across. That's so big, to have it all at the same time, ideally.
100%. It's almost, we say to patients, it's like I'm rebooting you. We're rebooting like an iPhone, turning you off and on, and really helping the kind of wiring in your nervous system reset, retrain
Yes.
it, because it's gone array. So we're trying to reset and retrain, which it takes some time, but if done properly with the right the right multimodal team approach, addressing all kind of the different layers of the nervous system and the fascial system and the muscles, that it works really well.
Yeah, exactly. And I think to really help, you know, with anyone that's undergone physical therapy knows that physical therapy can hurt. Right? You know, on one hand, there's the no pain, no gain concept, and on the other hand, we're teaching them don't follow that rule. It shouldn't be pain, it shouldn't hurt, you shouldn't flare. But I think sometimes people experience the discomfort that PT can sometimes offer, as well as the discomfort that injections offer right away. And if their brain is in such a habit of interpreting pain as something scary or something bad or even damaging, then they're having the wrong understanding of what's happening with their body when they're experiencing those things. And so part of the Retrain Your Pelvic Pain course really helps them understand this is why your nervous system is reacting this way. And this is, you know, almost teaching them accurate things to expect with these different interventions and helping them understand how they're working and what they're doing. So that way we're really trying to calm down the fear response. I'm flaring, or I'm having a little bit more pain after PT. That must mean it didn't work. No, actually quite the opposite. Let's look at what your body's doing. Let's look at how recalibration looks like, and really helping it parallel with another experience that they've had. So if they've had another injury, say a shoulder surgery, and gone through PT, they're like, oh yeah, I knew it was going to hurt. I didn't challenge that it hurt. I knew that was part of the healing process. Okay, let's bring that experience over to the pelvic floor PT. And again, we don't want it to hurt, but we want to learn to read our body's signals accurately, and be able to get the mind involved in terms of visualizing what do we want it to do? How do we want it to help? And how can we talk to the providers to see if if the sensations that they're feeling are normal?
100%. 100%.
Yeah. How do you, go ahead.
There you go.
When a patient asks you, say after an injection or even during the injections, right? Some people say that, you know, it's scary to receive an injection, or it scared them, the pain that they felt a little bit afterwards. How I can go into kind of how I explain it to them, but I'm curious as to how do you explain and kind of normalize what's normal pain versus what's not normal pain, something to experience after that?
Yeah, that's a great question. I mean, conceptually, the procedure that was created that we do is with a tiny needle. It's a 27 gauge needle. One of them is longer to get to where we need to go, but it is very small in diameter. So it was created for comfort and safety, honestly, and also increased efficacy as to where we're putting it, but really comfort and safety. So the majority of patients really aren't affected. They go on with their day. They go right to work. They'll go to dinner if they have dinner to go to. The one thing we say is don't go crazy at the gym right away until the next day. That's the majority. I'd say patients that can potentially flare are ones that come in with a chronicity of pain greater than 2 years, so they can be more sensitized than the rest, just because they haven't been treated, right? So they haven't been down regulated. It just gets worse and worse, that central and peripheral neurogenic inflammation and sensitization. So so we can kind of tell based on the way they're presenting to us by some symptoms in the exam who may have potential. But it's probably about 10% or less than 10% of our patients. But majority honestly don't feel much. They feel pressure, but afterwards they're not feeling much. So if they are, then we would say for the females, quite often it feels like a menstrual cycle, probably because it's very kind of clamped down in the pelvis, and we're really trying to increase the space. So that secondary kind of spasm or menstrual cycle cramping could happen. Mm-hmm. If there is a flare, we always have a prescription strength NSAID, so like an ibuprofen medicine, so that they can take it, and then also heat, warm baths, and sometimes a suppository of a muscle relaxer will help them as well. So that's kind of, and then if they have any sort of meditation, breathing at home, we always review that. That can also help calm down their sympathetic parasympathetic response if they're having a flare. But yeah, that would probably be the one thing that we do ever see. It's very, our procedure is extremely safe, but we do see flares, and it's about 10% of our population. So again, not very common, but we always do kind of discuss it and let them know if it happens what to do.
Yes, exactly. And I love that you made two important points that I wanted to make. One being there's a lot of feedback in how they respond. And one thing we say in neurolinguistic programming is that there's no failure, there's only feedback. So how someone responds to any type of treatment or intervention, whether it's therapy or physical therapy or injections or medication, that really is letting us know what the status of their nervous system is and what the status of their brain health is truly. And not to say, okay, oh, they're telling me that it's all in my head again. No, there's a real chemical process and a real change in the anatomy of the synapses, not only peripherally, but in the spinal cord and in the brain, that really does amplify every experience, let alone something that's in an area where there's been significant chronic pain, which to the brain is interpreted as trauma. And so I use the example a lot of phantom limb pain we're battling. We're battling, again, the acute pain issue of, yes, there's muscles spasming, yes, there's nerves firing, yes, there's inflammation in the body, there's real stuff happening. But when it's mixed with how long it's been there, then you're also adding in phantom limb pain as far as the brain reacting and the nervous system reacting as if it was the original injury was just now, let alone 2 years ago. And so that's kind of a double whammy in the nervous system when it comes to the brain and the nervous system just reacting to all of the above all at the same time. And so there's that education and understanding so they don't have to be afraid of it. And we see that pain education decreases flares and decreases the intensity of flares. So just some of this information that's gone over in the workshop in and of itself, we know is going to help the patients decrease their pain and manage their pain more effectively. But then as you start going into also the practical applications, like practical things that we can do that, certainly is on websites and blogs and different things like that around pelvic pain. But sometimes hearing it from an expert like yourself can just make something that feels so overwhelming, simplify it and say, these small little things can be so effective at calming the nervous system and calming the nerves responses.
100%. I love that you use the phantom limb example because it's mind-blowing in residency when we first learned about that concept. It really is a mind-blowing, interesting concept. But that's why when we open up kind of describing PRM and our approach, that concept of neuroplasticity, the fact that your nervous system can change, right? It can move in positive, negative directions. And that's what the whole kind of world of rehab was founded on. But that's a great thing in the chronic pelvic pain world, because if your pendulum swung here, we can bring it back. Takes time, repetitive techniques, usually repetitive desensitization, decreasing that neuroinflammation. But it's great to know that at the deepest level, at that neurobiological level and at the mRNA level, you can make a positive impact on your nervous system. So, which is just amazing, and how cool our bodies are.
It is. And the nerd inside me just loves all the all the science and the brainy stuff. But I think it also makes it digestible and less scary to patients when they really understand, okay, this is what's going on, right? Even if it doesn't change their pain in that moment, to be able to think about it differently and respond to it more effectively helps bring the power back inside of us. I think a lot of Western medicine gives us the idea that we don't have control and that all the control is with the doctors. But what I love about PRM is they really bring it back to that shared, it takes a village to heal. It takes a village to really work with not only what PTs and physicians and kind of the Western medicine can offer, but really reminding the patient themselves of how much control and power they can have, and they do have, and they need to have over their own healing process. And part of that is grabbing a hold of what channel their mind is at. But again, basic talk therapy, what we know in some of the neurobiology of trauma and chronic pain is that talk therapy alone isn't going to shift it. Fear can only be unlearned experientially. And in that being helping the system, helping learn how to kind of hijack the system back and calm the nervous system, calm the fear response when there's that muscle spasm, when the nerve is firing. And it's re-experiencing their bodies in a different way without fear is not only what can change the pain response, but it also changes the trauma response. And so often I'm talking to people about even generational trauma, not only the genetic aspect of things like endometriosis and painful periods and irritable bowel, and how that changes brain mapping and how that predisposes people to have certain pain and inflammation in certain parts of the body. But if they've observed that growing up, if they observed their mom being in a lot of pain, or if they learned that something about that part of the body is shameful or scary, that adds to the body's reaction to anything that's done in that part of the body. And so I'm sure, you have seen the difference between patients that respond to PT and injections differently if they are aware of their trauma that they've been through, or aware of some of the generational trauma. And so how do you tell the difference? What are some things that you notice, or how do you pick up on it in patients? And then I'll kind of talk about what we can do about that.
Sure. So trauma in general, or more of a generational trauma patient?
Both.
Yeah, I mean, with trauma in general, we do ask them. We've had a lot of coaching around that kind of trauma informed patient care approach. Over the past kind of 5 to 7 years, I've toyed with how to do it, but right now we do ask. That's one straight off. Has there been any trauma in your life, and that you like to let us know about? The other thing we do is sometimes we can also just build relationships over time, and then sometimes when the patient feels comfortable enough, they will just bring it up. The other thing we do is we really do look at patients that are just hyper sensitized, and again address them not necessarily as trauma, but in a way of just knowing that you really have to take a more gentle approach, I would say. And in terms of trauma versus when patients have had some sort of genetic condition that can be passed on, and the most prevalent one that we see and treat would be for sure endometriosis, we are asking a detailed kind of family history. And of course we ask about a family history of endometriosis, but also just, do you have a family history of pelvic pain, of a hysterectomy for an unknown reason? That's very common. I don't know, my grandma or aunt had a hysterectomy, but I don't know why, but they said they were uncomfortable. Because quite often, particularly 5+ years ago, was even more challenging than it is now to get a diagnosis of endo. So then we'll ask just a very detailed family history, and of course a history of discomfort around speculum exams, and anxiety around speculum exams at the OBGYN, which can be not trauma or not. The challenging aspect, our most challenging aspect, is quite often there is such a prevalence of endometriosis in our patient population, but sometimes that can come concomitantly with trauma. So it's very challenging to kind of decipher the impact of it all, and you just have to really take that holistic approach and just really work on all of it.
Yes, yeah, absolutely. And I love everything that you're saying. I mean, you're touching on the medical traumas itself, just going through something like pelvic and sexual pain and endometriosis. And what I have known, what really stands out to me about the physicians at PRM is that they are so in tune with the body language that a patient is giving off. And even if the patient doesn't feel like even if they don't self-identify as having trauma or knowing about a history of trauma, the physicians are really tuned into how the patient is responding to even approaching the pelvic exam, let alone talking or talking about that part of the body or engaging with that part of the body. And they don't push the patient past their comfort zone. If anything, sometimes I've noticed that the physician recognizes that the patient is in distress before the patient even verbalizes or acknowledges that they're in distress. And that is very different than so many other stories that I've heard, where they're like, okay, well, just grit your teeth and let's just get through this, right? There's so many providers, both, in all fields, that really push the patient through that and just kind of say, grit your teeth and deal with it. Or they'll say, I'll have a glass of wine next time before you come, or they'll really dismiss it. But you guys do an amazing job of really saying, you know what, there's something to this. Something's happening here and we're not going to push through it, but let's get you to say, Dr. Milspaw or someone else that can really help their nervous systems regulate and really help, again, empower the patient to be able to calm their system, to be able to do what they're wanting to do, whatever that medical intervention is, without it being re-traumatizing. And one thing I'm always talking about is sometimes we don't know what the trauma is, but if the body's trying really hard to protect you, then it's doing a good job. That's its job.
Yeah.
We just have to help the body say, right here, right now, you're safe. And what helps create safety. And as you said, sometimes we can create safety in one session. Sometimes it'll be just creating that rapport that the patients do with the physicians at PRM, and that in and of itself helps create safety. Sometimes it's, is the partner in the room or not? That can make a difference. There's just so many variables, but I think tuning into recognizing that it's not just a mental issue that we're addressing within the behavioral health department. We're really looking at how is the body responding, what's happening, and what does that tell us about the history of the nervous system, whether it's conscious or subconscious, whether it's known or unknown. Certainly with sexual pain and hysterectomies and things like that, again, we just started talking about that societally within the past 10, 20 years. And so many people have never talked to their mothers or grandmothers or sisters about painful periods or painful sex, we just didn't have that foundation to talk to about it. So they really don't know. So yeah, I really try to help them understand there's no, when it comes to the brain, there's no difference between trauma and pain and stress. It's all perceived in that same filter. And so we have to treat it the same.
That's amazing. That's amazing. It's so true. And its effect on the body, it's all similar.
Yeah. I start off sometimes with, I should have had this image ready, but there's an image in so many of these the research literature of the activity of the brain as well as the hardware of the brain, and how in both the cerebral cortex, which is the gray matter and all the squiggly stuff that surrounds the brain, right? Those are the main highway systems between the left and right hemisphere. And then there's the anterior cingulate cortex, which is like a horseshoe right in the midbrain. And with both of those, it loses mass and it loses function. So sometimes the cerebral cortex can shrink up to 50% only within 2 to 3 weeks of being in pain, let alone so many of our patients have been in pain for 5 to 7 years. And then the midbrain becomes quiet. So I kind of say, look, the bridge is out. The left and right hemispheres aren't able to communicate the way we need them to when we're processing life in general, let alone when we're asking the body to register and perceive physical signals differently, as a muscle spasm versus extreme pain, or again, all the different neural nets that can get drawn into the emotion that they've experienced when they've had pain, whether someone's respected them or not. All these different dynamics of what goes into a memory of pain, and then when they've had pain for so long. And so when we see these brain changes, I'm saying, look, yes, your pain is in your head, but that's just because your brain happens to be in your head. But there's an organ health issue, and the brain is the only organ that we tend to not look at and scan and do. We can't do a laparoscopy in the brain, but if we would be able to more easily, we would be able to really see it. And seeing is believing, as they say. It's like there's a real issue here. That's why you're catastrophizing. That's why you're ruminating. That's why your brain is stuck on this kind of what I call a traffic circle. And so many other therapists I've seen or worked with, and even healthcare providers, they really blame and shame the patient for, well, that you must not want to get better, or you're not trying hard enough. And we see that even a lot in the addiction world, where the blame and the shame is placed on the client or the patient, and there's no recognition of how the brain has changed, and we're not helping them heal the brain, right? If we're not, it's like yelling at someone because they have constipation or diarrhea without teaching them that there's a health issue with the GI system and why we have to heal the GI system, right? It just makes it more almost objective and manageable when we can really see it for what it is, rather than this really abstract concept that mental health has been for so long.
Completely agree. It's a silent disease process. So it's that synergy that we are oftentimes dealing with in the pelvis too. It's that, that silent disease process. And you're right, is believing. So that is both of our biggest challenges, trying to kind of, get to the root cause and draw those connections.
Yes.
Okay.
And I feel so lucky to work with PRM, because all the physicians you have on are really engaged and passionate about bridging the medical and the psychological worlds. I mean, we're all communicating. We truly are working as a team. It's not, oh, I don't know about that, you talk to Dr. Milspaw, or I don't know about that, talk to Dr. Shrikhande. It's saying, no, we're actually going to communicate. We're going to work together. We're going to communicate with your physical therapist. We're going to get you to a nutritionist that understands pelvic pain and not, that doesn't know how to speak to it specifically. So I just really love the collaboration. I think the patients are really benefiting from that in a multitude of ways. One, they feel taken care of, but B, it's obvious that we're communicating, and so they're not having to repeat themselves from one provider to the other, but we're also really able to share feedback and share the same language. So language that you're using, they hear me using, and vice versa. So they're not feeling so confused anymore as they do sometimes when they're working with physicians or healthcare providers that aren't communicating. They can get really confused with the mixed messages.
Oh, 100%. Yeah, I was in DC last week, and yes, a patient said, Dr. Milspaw reiterated that to me. And you do need that reiteration of complex concepts, but just explaining it. How do you apply this to your life? How are we going to apply it to you to essentially help you get better? But if you're hearing it from multiple people and then communicating, it's a necessity with our patients to really get them better. Is we need to all work together, and you're right, be on the same page how we're addressing this complex disease process.
Yes. And I think with pelvic and sexual pain, we tend to only go towards certain physicians. I mean, I know it wasn't until I met you that I learned about physiatry. And I think you and I were presenting at the Pudendal Association, and I saw your talk, and I was like, yes, of course. Why aren't physiatrists the first stop with pelvic pain? But I think I really want to get the word out there, as far as even if they're seeing other physicians that do know or say they know about pelvic pain, I really think it's important that they talk up to a physiatrist, because there's usually so many aspects of their pain that aren't being addressed. Some of the pieces are, to the best of other, the provider's abilities. But I think, again, that the bigger picture, the whole picture that physiatrists really look at is necessary. And how do you explain, when patients come in and you're recommending, say, the Retrain Your Pelvic Pain course, how do you explain that correlation, kind of why it's important for them to do the course?
We explain overall, all the physicians really explain the importance of chronic pain education, of connecting their specific symptoms to what's going on in the nervous system, both the central and peripheral nervous system. Mm-hmm. And then the importance of really down-regulating. We describe it as the nervous system almost has ADHD, right? It's both the peripheral and central. They're just firing inappropriately, and we need to calm it down. And of course, certain oral medications are helpful, but really to get the most effect, there is a specific program which Dr. Milspaw created that really targets calming down the nervous system, and really the most kind of natural way that will also be, long lasting. If you can figure out how to really adopt this and, again, change it at the deepest level, you can continue it for life. So it is a long lasting approach. And then also giving you techniques to do at home, mindfulness, of course, meditation, muscle relaxation techniques, which it's really nice to do, A, in a group setting, but B, surrounded by people that all have pelvic pain, so you're not alone, and then with an expert such as yourself, someone really paving the way and a pioneer in describing these techniques for really the pelvis, and it's never been done before. And it really makes a big difference when you go to someone such as yourself, Dr. Milspaw, who does it all day, every day. Mm-hmm. Well, you can talk about vulvodynia or pain around erection or intercourse, and you've heard everything. So it's you hear it all day, every day. It's just experience, and you're addressing this specifically.
Yes, exactly. And so I think I'll use that as a segue to talk about what each week focuses on, so it's a 6-week course, and each week is now at 2 hours, which usually leaves a good 15 minutes for Q&A at the end. And I've had a lot of interaction with those that have participated in it, which is great because they ask questions I don't even think to address. And so then every time I run the course again, I make sure I insert that, but they're really sharing dialogue on the Google Classroom and sharing resources with each other. So it really is creating a great community, which I love. And I utilize something called Poll Everywhere, which is an app that they can participate and kind of give their answers to while still remaining anonymous. But with these answers, they really see that they're not alone, because they're like, oh my gosh, okay, there's 50 other people in this course with me, and all of them have expressed a sense of hopelessness or anxiety or frustration or et cetera, usually in the beginning of the course. And then as I infiltrate kind of various different exercises throughout the group every week, I ask for their feedback of how does this make you feel, or what did you notice happen? And they're able to see that growth and that healing that's happening with everyone at the same time, which I think in and of itself can really inspire hope for healing and an understanding of that healing process. So that's a little bit of kind of the way it is, the outline of it. So it's both educational and experiential. So I'm talking them through the science of something, then such as pain, and then I have them do an exercise where they're applying that, whatever I just explained scientifically. Okay, now let's do an exercise that applies that, such as I have them create a body map, and they'll do a little outline of a body, and I'll say, okay, tune in to a time when you felt afraid. What does fear feel like? So really tuning them in experientially to that mind-body connection of how fear or any emotion or thought isn't just in the brain, right? They feel maybe tightness in the chest or a heat, or, not even in the body, but they feel kind of an energy outside the body. And so just drawing those brain maps of what does pain feel like and what does safety feel like. And this week we're talking about relationships. And so we're going to talk about how the neurobiology of pain and distrust and fear is the same neurochemical magic that happens when there's safety, or is the same neurochemical magic. So one can lead to another. So if there's pain and fear during, say, a sexual or intimate experience, that's going to create detachment from a partner. And that can be very confusing for people. They can say, why is it that I feel like I can't trust my partner, but they didn't do anything? And I'm saying, no, there's a chemical reaction to love and attachment and desire. And when you do the opposite of that, then it's going to break attachment. And so I'm excited for this week, because this week really going into how pain affects relationships, which is more delved into during the other workshop series, which is Reigniting Intimacy for pelvic pain, for those that navigate pelvic pain. And with that course, I'm going into a little bit of the brain biology and the anatomy of pain, similar to the Retrain Your Pelvic Pain course, but really briefly and more so helping people focus on reigniting and how to create, again, neurochemically, let alone emotionally, how to recreate trust within themselves as well as with their partners, and really how to help their bodies remember, right? Coming back together of what pleasure is like. How can they feel safe and comfortable with pleasure, not necessarily jumping into penile vaginal intercourse or any type of penetration, but again, intimacy isn't about penile vaginal intercourse or penetration. Intimacy is about closeness, it's about trust, it's about connection, and it's about pleasure. And so that's the other course. But the Retrain Your Pelvic Pain course is pain education, looking at pain maps and brain maps, looking at their whole timeline of this is, your brain is responding to everything you've gone through, let alone everything ancestrally that has been passed down to you. And so we have to help the whole system learn how to neutralize those things, again, experientially through bilateral stimulation, through breathing exercises that calm the nervous system, learning these, what I call how to kind of hijack the nervous system back. So how to get the vagus nerve to calm down, and even something like gargling water or humming is a way to really shift the nervous system. And so I go into all these 2 to 3 minute exercises, which usually is all they have the attention span for in the very beginning when you're in a high amount of pain. And then, step by step each week, we get more and more into the mindfulness and healing the brain and healing that brain gut connection. And then really by the end, learning how to how to practice mindfulness with your partner, let alone practicing longer versions of mindfulness by themselves, because that takes a longer attention span, some of these 10 to 20-minute meditations. And if you try to jump right into that, the brain isn't ready for it. And so people can get really frustrated that says, well, I'm not a mindfulness person, or I don't have that personality. And, or they feel like they're doing it wrong. And once again, they get into a judgment or a shaming. So it's really wanting to take them through a step-by-step process of, here, we're going to heal your brain. And it might take longer than 6 weeks, but they definitely have the foundation that they need of, and the experience, right? Them experiencing it in session is so key, because they're more likely to practice it outside of session if they experiencing it during the course. And then they have access for 6 months to all of the resources and the recordings. So I encourage them to kind of take the course again as they re-listen to it over the next 6 months. And we're getting great feedback so far. So
Amazing.
It's exciting.
No, amazing. And this is all really pioneering work that you're doing. So it's really so cool to hear the detailed level description. But how do you personalize meditations? How does that work?
Yes. So what we do know is similar with cellular memory of that can happen, say, if someone has pushed through pain and then they're trying to get a pelvic exam and their body retreats, right? So there's that cellular memory, there's that muscle memory of pain, and that causes the body to react in a certain way. Well, with personalized meditations, we do exactly that, but the opposite, in terms of we're tuning into a memory of a time when they've felt safe, a time when they felt relaxed, and when they felt peaceful. And so when I utilize a memory of a time when they have felt safe, relaxed, and peaceful, and I use that as part of the guided visualization, that really relaxes the body even more so than, say, your basic, let me take you for a walk on the beach type of visualization that some, there's tons of meditation apps out there that are absolutely fabulous. I mean, there's Insight Timer, there's Headspace, there's Calm, there's so many other things that I'm not even thinking of mentioning. But whenever I create a personalized meditation for someone, they are always amazed at how much more powerful it feels, because again, we're tapping into their own cellular memory and the body's like, oh yeah, I remember that. Right. And they revisit the memory, and that in and of itself wakes it up on a physical level that really deepens the relaxation for them. And then usually some people like to insert phrases that they want to believe, or what they want to really want to focus on, such as, every day in every way I'm feeling better and better. I allow my body to heal, and I'm ready to live the life that I love. Or, some people bring in different song lyrics that they like, or, religious statements that they like, or just overall positive affirmations. Because when the body and the mind are relaxed, we become more open to change. We become more open to thinking differently. But if we're in a stressed out space, and if we're in a lot of pain, and someone says, so I'll just think positively about it, it almost makes it worse. The brain says, no, this is why I'm upset. The ego part of the brain steps in and gets ready to fight for us, and we don't know how to let it in. So when we can really relax the system even more so using a personalized memory, it just makes it work more effectively and more efficiently.
It's so true. It's just like anything else in life. When you're in a chronic pain state and we're trying to change that, right, to get you into a more kind of calm, happy, less inflamed state, you have to be open to it. And you're not prepping the body to receive. It's very challenging.
Yes. And sometimes with personalized meditations, I might just use, instead of a memory and versus a kind of a guided visualization, it might be more so metaphorical. So if someone is a mechanic, I might talk them through a mechanical metaphor of how pain is processed and how the body's going to heal itself. Or if someone's a gardener, I love using the garden metaphors. But the power of metaphors is kind of a backdoor to the subconscious mind, where we can help someone not only understand the pain processing, but understand how the body heals, versus, in a metaphorical way, instead of saying specific, like, okay, your hippocampus is doing this and your anterior cingulate cortex is, right? All this kind of medical jargon can sometimes overwhelm the patient, and they're like, I have no idea what you just said. But if I say, okay, first we need to till the soil, then we can plant the seeds, and then we need to water it and give it sun every day. And they're like, okay, I understand that. It's like, okay, a plant's not going to grow within a day. So injections aren't going to work in a day. PT's not going to work in a day. Trauma work or therapy isn't, we can't heal your brain in a day, but it takes time. And so using metaphors within meditations can really, again, be kind of a backdoor to the subconscious of saying, this is the concept I really want you to understand. And when we understand it, all of a sudden there's that trust in their body again. There's that trust in the whole process that PRM physicians are doing or that the PT is doing, because they get it. And we just need to help them get it. And as soon as it clicks, we really see a shift in their fear response decreasing when it comes to how they experience their own bodies and the pain reactions.
Amazing. That's,
yeah.
I love it.
Love the brain.
I feel that.
So,
yeah, I mean, for you also, when you are kind of doing these personalized meditations, I'm sure there is some sort of positive kind of neurohormonal response going on as well, positively affecting, the HPA axis, that interneuronal neuroendocrine synapses that do occur in the brain, spinal cord, pelvis, everywhere. So.
Yep, exactly. What a lot of the exercises that I teach are utilized to increase oxytocin, which we know decreases cortisol. And when we decrease cortisol, we can also increase testosterone. Testosterone being that sense of the hormone that gives us courage and helps us feel confident in what we're doing. But oxytocin also really being that bonding hormone. So it just helps them feel safer. It helps them bond with themselves or bond with their partners. And just seeing we get into what's called bliss brain. So Dawson Church has a really great book out that's called Bliss Brain. And he looks at a molecule that's really, there's a different name for it, but he calls it the bliss molecule. And so when you get into a really deep state of relaxation and really feel peace, there's a neurochemical, molecular change that's happening in the brain that in and of itself calms the vagus nerve, calms the polyvagal reaction, calms neuromuscular activity. I mean, it just, and creates happiness, the happy chemicals in the brain. So it's, again, when we understand what's going on and then we know what changes it, it's like, okay, let's just put those together and notice the magic start to happen.
Notice the magic. Wow. It's great. I love it at the deepest level. Really.
Yes. Yeah.
Amazing.
Yes. So, I guess more information is certainly on the website. We now have the online registration for all of the courses. And during the weekly support groups, we really go into practicing some of these exercises, and so people can get more practice doing what they're learning in the course, but also just talking to each other and again, sharing stories and sharing the support that's out there, so it doesn't have to feel so isolating and it doesn't have to feel so strange. Really emphasizes the unfortunate piece of how normal it is to be going through something like this, but to also normalize healing from it, because I think that's the message that's not out there enough.
100%, exactly right. And that healing is possible, particularly when you're working with, a high-level team of different experts in the world of the pelvis, putting their brains together to try to figure you out, right?
Yes. Yeah, absolutely.
Maybe recap your different courses that you offer, because we did go over them, but just a recap of the different options.
Sure. So there's the main one I think I would highlight is the Retrain Your Pelvic Pain course. It's 6 weeks, about 2 hours each week. And again, with registration, you not only get a bargain as far as getting all 6 weeks for $300, but you get the 6 months access to all of the recordings and the handouts. And again, I understand the brain can't absorb all of that all at once sometimes, particularly when you're navigating pain. So the access to be able to listen to each class again and again is key. And so I want them to know that we make that available for them. And that's really the main aspect of pain education and learning concrete evidence-based skills that help neutralize fear and pain and reprogram the brain, which is beneficial for anything, let alone pelvic and sexual pain. And then a good follow-up to that would be the Reigniting Intimacy course, which is a 4-week course, again, 2 hours each week, and it's every other week, but that's for couples or partnerships that are navigating chronic pelvic and sexual pain and focused on reigniting intimacy, reigniting connection, and how to build trust and pleasure again, even if you're still in the midst of healing physically. And then there's the two support groups. There's the male pelvic pain support group and the female pelvic pain support group, which is mostly, we speak to male or female anatomy. So it's the only reason we really separate it out. And certainly we're looking towards creating a kind of a non-binary gender support group for those that are not wanting to identify with either male or female anatomy. And then we have the Thriving with Endo course, and that's a fun one. So the Thriving with Endo course is for any of the patients that are preparing for or recovering from endometriosis surgery. And I go a little bit into, again, the mind-brain connection, but a lot of practical applications or practical things of what can they do and why they need to do it and what they can do to prepare the whole systems, let alone their mind for this procedure. For optimal outcomes, as well as things that they might not have thought about to have for recovering afterwards. And so every week there's the Thriving with Endo course on Thursdays, and then that's followed by the support group, which can be really, again, a good way to take everything that they've learned in the Thriving with Endo course and applying it and practicing it within the female support group.
Love it. And how can people sign up for your courses? Through the website?
Yep, through the website. So pelvicrehabilitation.com/courses. So it's nice and easy. And they can click on the course they want, and they really register and pay for all of it at once. And then they'll receive an email from us with, to continue filling out the consents and some of the other details. But the Retrain Your Pelvic Pain course does currently run 3 times a week. So there's 3 different time options. And that's mostly to benefit either people that work first shift or second shift, but to also be able to tune into different time zones, because we're wanting to serve as many people at once. And so hopefully the different morning ones on Wednesday and Thursday can be able to be accessible again to either someone that works second or third shift or someone that's more in mountain time or Pacific time, so they can join in on the healing fun as well.
Thank you, Dr. Milspaw. Everybody come check out Dr. Milspaw and all her amazing courses for pelvic health, chronic pelvic pain. And yeah, we're super excited, and I'm really excited about benefiting our patients and working together. PRM's approach with outpatient interdisciplinary approach to treating chronic pelvic pain.
Yes, and I love it. So come join the fun. I should say, you don't have to be a patient to take the course. So I am, a lot of other physical therapists and healthcare providers and physicians have also taken the course or are signing up to take the course, because it not only gives them the language that they can be able to utilize and talk with patients about, but it also helps with their own self-care. There's so much secondary trauma or vicarious trauma that is in the world of working with pelvic and sexual pain, let alone chronic pain in general. And so I want everyone to know that there's a little bit of everything, there's a little bit in the course for everyone. And so certainly, the more the merrier.
Great.
Yeah. All right. Well, thank you for your time, Dr. Shrikhande. I will see you soon.
Thank you, Milspaw. Have a good evening.
Bye.